Good morning here at the Tickenville Ballroom at Case Western Reserve University. Good morning to all of you who are joining us virtually. I'd like to share a story with you. Hope lives in rural Louisiana. Hope is pregnant with her third child. During her last pregnancy, she became severely anemic and she developed diabetes, which require constant medical monitoring. The closest clinic, which was about 10 miles away from her mobile home, recently closed. She has limited education and economic opportunities, so she couldn't move to a neighborhood closer to a health facility. 7 months into her pregnancy, she developed severe complications. Hope died before help could get to her, leaving behind a family mentally and economically scarred. Why should we care? Hope can be any woman living in resource-poor areas from any country. Researchers say that out of the estimated 139 million women who give birth every year around the world, 289,000 die, and another 2.1 million develop morbidity. This begs the question, what are the factors that continue to perpetuate such low maternal health outcomes in rural areas, in resource-poor areas? In order to find out what that was, we developed a study and interviewed over 100 health professionals. And they all point out to 4 key social determinants: education, income, distance, and utilization of health services. If we want to slow the rate at which women die, we must address these factors as a society. Mohamed Fastala, who's a prominent obstetrician from Egypt, once said, "Women are not dying because of diseases that we cannot treat. Women are dying because society has yet to make the decision that their lives is worth saving." That's why we're here today, to have a conversation about how we as a society can support women, empower women to take charge of their lives and health so that they do not die while giving a life. And in order to have that conversation, we invited a panel of 4 professionals who work directly with women, and I'll introduce them in a few minutes. I want to pause here and thank the Weatherhead School of Management and Inamori Center for giving us this opportunity to bring this conversation to the table. And before also I introduce the panelists, I want to go just over a couple of housekeeping. For our colleagues who are friends who are listening virtually, you may ask questions. We have somebody here who can monitor these questions as you ask them. And you who are here with us physically, don't hesitate to interrupt. And if you have any questions or comments about the discussion, please don't hesitate. So without further ado, I'd like to introduce to you our first panelist, Dr. Bode. Dr. Bode is from here locally in Cleveland, and she's a family medicine physician who has served in inner city and vulnerable populations in the greater Cleveland area for more than 20 years. She's a native of Nigeria, and so she graduated from the University of Ibadan. She completed her residency here at Metro Health and at Case Western Reserve University. She practices full spectrum of family medicine, including women's health and obstetrics. I'm a French speaker, so sometimes I mess up English words, sorry about that. And her clinic and non-traditional sites, such as the county jail. Her focus in the last decade has been disparities and upstream, downstream effects. Dr. Adebombo was instrumental in developing pedagogy to address the gaps in healthcare, culminating in a book several years ago called Health Disparities, Waving New Understanding Through Narratives. And she's now working on a second book, which is extremely important for all of us, is how health professionals address racism, microaggressions, and allyship. Our second speaker is Dr. Ok Pannenborg. Dr. Pannenborg is a retired chief scientist of the World Bank, and he brings to this conversation his global knowledge, and he has worked in over 20 countries in various organizations, including the World Health Organization and the United Nations Commissioner for Refugees, And while he was at the bank, he was responsible for all the health sector and for all the countries. So you can imagine over 180 countries are members of the World Bank. Dr. Pannenborg also served on the board of the Netherlands Commission for Program and International Health. And he brings to our conversation his experience in law, in international relations, in medicine, and at the tropical level, and as well as business and management. Our last speaker, and I introduced her last because we are the host of this conversation, we, the students at Weatherhead School of Management. Our last speaker is Vijaya Paraswaran. Vijaya is a clinician and a dietitian from Stanford University, and also a PhD student at the Weatherhead School of Management. She's a social scientist and researcher at the Division of Cardiology at Stanford, as I just mentioned. And Vijaya brings to the table her experience in nutrition and telemedicine. So, having said that, if I may give our speaker the floor to give their introductory remark. Dr. Pannenborg, the floor is yours.
Thank you very much, Tshiya. Let me just share with you a few thoughts that I have on this topic, which I think is important. Many of us, when we think about maternal health, and when you read that in the newspapers or you're on social media, you automatically and instinctively, you think, oh, somebody in the hospital needs to do something about it, or in family practice needs to do something about it, or nurses. Now, the study that Ms. Subayi just completed shows that the factors determining maternal health, the health of women, to a very large extent, are outside the more narrowly defined health and clinical environment, and that there are factors outside that play a big role. Now, the moment you go outside clinical medicine, you end up in, for example, the institutions here that some of you are associated with, meaning a school of management. We know that 50 or 100 years ago, a health center or a hospital was also managed, end of quote, by clinicians. That's no longer the case. Most larger institutions are managed by economists and management specialists, etc. So it's those professions who need to be alerted to the factors that ultimately determine the health of these women. And so it's in a way logical that this effort is being pursued within the School of Management. And then within the school, you have this Inamori Center. And I'm very pleased that when I learned that, because Mr. Kazuo Inamori was a big and very prominent manager himself. And it's interesting, the center is called the Inamori Center of Ethics and Excellence, I think. Now, Kazuo Inamori was a very significant Japanese businessman, but with an aura that went beyond business. So there are, after the Second World War, when Japan was defeated, of course, and then became a big industrial power, there are kind of in anecdote and lore in Japan, there were three major industrial leaders. Mr. Morito, who created Sony, and then Kazuo Inamori, who created ceramic, and then electronic ceramics later, and then the third one, I forgot the name. But this Kazuo Inamori, he insisted that in business you had a wider perspective. And you can see that from the fact that while being among the most prominent industrial leaders in Japan, at the same time, he was a Buddhist priest. So here he highlighted, let's say, he used to say to the employees of the different industries, respect divinity and love people. See? Now here we go into this world now, of maternal health. How do you marry that with ethics and the reason why we address this? And you can see how that creates a common area where we go beyond pure clinical medicine or admitting patients or managing the finances or a women's health center, etc. So this comes into the world that we are discussing here. And then finally, I'd like to start with an element to share with you and to show you how, in my view, this remains an unusually relevant issue. As you can see, together with a few people in the audience, I'm of the older generation. I wrote my first book about global health in the late 1960s and the early 1970s. At that time, maternal mortality in Africa was around 1,200, 1,400 per 100,000 live births. The number, as you can hear from my accent, I'm originally from a small country called the Netherlands. The maternal mortality in the Netherlands at the end of the 1960s was 6. So 2 or 5 or 6 or 1,600, that's almost a factor, 1,000 difference, right? Now look at today. Now we are more than 60 years later. Maternal mortality in Nigeria, in Chad, in some parts of Africa, and remote parts of, let's say, India, etc., today still stands at 1,000. Maternal mortality in Singapore or Finland is essentially 0. See? So 60 years later, we still have a factor 1,000 difference between the very rich economies and environments and the very poor parts of the world. So it remains highly relevant. So let me stop there in terms of we have a little bit of time later, and we'll come back to some of the social determinants of these patterns, but as an introduction, I think that's fine.
Thank you. Thank you, Dr. Pannenberg. Dr. Bodhi, you have the floor for your introductory remarks.
Hello, good morning. I am a family medicine physician, as you've heard.
So you can share, and then if that one's not, just give.
Hello. Okay. Yeah. I'm a family medicine physician, and I work in the inner city. And I was going to share with you some of the women I'm privileged to take care of in my practice. But before I go to do that, I'm just going to say something of what you've just heard regarding our health as a whole. Now, what it has been shown is that our health as individuals, most of it actually depends on what we call social drivers or social determinants of health. In that whatever we do in the office or in the healthcare system really contributes about maybe 10% of your total health. And it's thought that these other social drivers make up to almost 60, in some places 80% of the health of an individual. So it's just something to think about based on what you've already heard, that the study showed that these are important drivers to what we're seeing with regards to maternal mortality in the United States, in Ohio, and in most places in the world. So going back to my practice, the women I see in my practice, really, I would maybe categorize into 3 different groups. There are those who are in the childbearing age that are coming for reproductive health, right? So reproductive health, which includes preventive health. It includes general health of the individual. So dealing with any chronic problems they may have, making sure immunizations are up to date, healthy lifestyles such as medications, staying away from drugs and alcohol and tobacco, right? And also things like making sure they're safe at home, right? And they have access to reproductive health needs such as contraception. So that's one group I see. Yes, that's a question. Oh, I'm sorry. Okay. Is this better?
Yeah, I guess you have to keep it a little bit closer.
Oh, closer to my mouth? Oh, is that okay? All right. So I was just going over the patients I see in my office. That one group would be those who are seeking reproductive health needs or advice, and they tend to be the reproductive age group. So it's really going over preventive health and all its aspects, teenage immunizations, making sure that cervical cancer screening is up to date, making sure that they have the immunizations for HPV or anything else that can affect their reproductive health, STI screening, sexually transmitted infection screening, and such like. It also includes healthy lifestyles, diet, exercise. The other group I see would be those who want to get ready to have pregnancy, preconceptual counseling. So want to maximize their health before they think about getting pregnant. And then the third group I see are those who are pregnant. And I actually have a fourth group of women I do see in my practice who are those who are past the reproductive age, so in menopause and older with health concerns that relate to that. So that's it in a nutshell. Now, what most of my ladies have in common is that because of the population I serve, the social drivers and the social determinants of health are really very similar and have to be addressed. So one of the push we're doing in the clinic is really trying to screen everybody for social drivers of health or social determinants of health, right? And we're doing that in various ways. And you'll find out that that varies from population to population, depending on where it is. A lot of the inner city social drivers include food insecurity and housing insecurity, right? If you go to different parts of the country or you go to the suburbs, it could be something else like social isolation or making community connections. So that's why it's really important to screen every individual and very specific individuals, because we know that nobody's life is static, right? So what could be true today might not be true next year or even down the road in 6 months. So this is just to give you a nutshell and a flavor of what my practice is like and how we try to serve women.
Since we're having a conversation, please allow me to go on a first name basis. So Vijaya, you have the floor for your introductory remark.
Thank you, Tshiya. Thank you, everyone. It's so wonderful to participate in this conversation. And I want to start by saying thank you. This is to the Inamori Center, to Tshiya, to the Vedahead School for bringing such an important topic and having a conversation about it. I think it's wonderful to be a part of just this conversation. Every time I hear Hope's story from Tshiya, I also see all those people that Hope has supported who are now left behind. I also see her partner, her family, and all those lives that get disrupted. So it's so much more than the health of the mother and the child, right? It's society. So we have to take ownership and we have to be accountable. I also find that this is a really special moment for me because here we sit at the intersection of management and medicine at a campus that worships both. And I'm grateful for the Vedahead School for giving us a platform to speak about such an important topic. So in the context of that, of giving thanks, I'm grateful that we're going to have this conversation. And some of the things that you will hear me talk about is the lens that I bring in, which is a more systemic lens. I think when we talk about maternal mortality, we are quick to think about the clinical conditions of the mother's health, as Dr. Ock talked about. It's so much more than the medication that gets prescribed. It's so much more than whether it's hydralazine or what do I prescribe for the preeclampsia, whatever it is, right? It is so much more than that clinical condition. It is about how is it translated into the community? How is it implemented? What are the contexts? So that's what you will hear me speak about in this conversation. I will do my best to try and bring into light the importance of systemic factors. And I'll also talk about the role of nutrition, malnutrition, and the role of obesity. So context and where we stand as a country, where we are in the global perspective as well. I hope that this conversation is enriching for you, and I welcome your participation. Thank you.
Thank you very much, Vijaya. As in any conversation, there's always somebody eavesdropping. And so we have a speaker that's eavesdropping from Geneva, Switzerland. And I would like to introduce Dr. Samira El-Tuodri. Dr. Samira is a physician and a PhD. She's the global lead for population and development at the World Bank. She was formerly a director of the UN Women, based in Egypt. I don't know if we can see, oh yes, we can see Dr. El-Tuodri over there. Yes, thank you. It's quite late in Geneva, but she agreed to be with us. Dr. Tuodri's experience has been very enriching. She has worked for the Arab states as the director, and she also worked as the director of the International Labour Organization, their program on public health safety. She served as I mentioned earlier, about the regional director for Arab states, and she's a board certified obstetrician. And she was educated here in the US at Harvard and Johns Hopkins. So Dr. El-Tuodri, you have the floor.
I come from Saudi Arabia, and although this is a high income country, but trust me, the issues that women deal with are the same wherever you go. And I would add to the title of your discussion panel, the fact that it's not where you live, it's actually where you're born that has a lot to do with your fate when it comes to health. So it's a kind of lottery. Just a few things to add. I cannot emphasize enough the role of the social determinants of health, whether it's poverty, gender, locality, and all of these things. I have built my entire public health career on addressing the social determinants of health or health outside the health sector, and those are extremely important. And I'm here in Geneva for the last 2 days because I sit on the board of the Human Reproduction Program, which is a special arm of WHO that's concerned with research on reproductive health. And we went through the array of everything, from unsafe abortion to the clinical management of postpartum hemorrhage to preeclampsia to menopause. And all of these are women-related issues. They only have women as their target, as their clients. And one of the things I wanted to add to the mix that had already been addressed is the role of society and the role of community, and especially the set of societal values. We often talk about demand and supply when it comes to health services, even if we are talking about community outreach and trying to get to these women or to these girls before they get pregnant. There is also something that had to do with the pickup, with the demand in itself, because one could build a state-of-the-art medical center on one corner of a street that provides comprehensive sexuality education, family planning methods for unmarried adolescent girls and what have you. But the girl on the other side of the street cannot access it, not because she cannot walk to it, not because it's free of charge, but because of societal values. And this also has a lot to do with safety of women, especially the violence against women. And I mean it in its comprehensive value, from female genital mutilation at an early age to domestic violence to forced and early marriage, and sometimes even the deprivation of where the woman wants to have her child. And we often talk about assisted deliveries and skilled birth attendants. And true, it is actually related to how much of a service is available, but also we need to be very mindful of how much of the service is being picked up by these women and these girls. And finally, I think the entire discussion on women health, whether it's reproductive or otherwise, and I am glad that I heard the word menopause in the previous intervention, is squarely anchored on women empowerment and women agency. When women have the power to actually decide what they are going to be doing with themselves and with their bodies, then the ball starts rolling on those all preventive services and all of those curative services and what have you. And core and center to the women empowerment is women economic empowerment. We know that women who have roofs on their heads and food on their tables, they have the dignity of not needing anyone, actually make better choices, not just for themselves, but also for their children, for their communities, and for their countries as a whole. Thank you again. I'll leave it there.
I don't know if we have any questions from the audience or any reactions online for the introductory. Todd, do you have anything so far? Okay, so we're just going to continue our conversation, and some of our speakers touched on very, very important issues. But one issue that has been and continues to be at the forefront of our society, not only here in the US, but around the world, is how we can bring the artificial intelligence into everyday and what we're doing, particularly into the health sector. So there are different forms of artificial intelligence. I think the COVID-19 pandemic showed us that telemedicine and telehealth works, and that having a conversation and having a partnership with the private sector saves lives. And so I'm going to ask you as health professionals to sort of help us share with us your experience in using artificial intelligence and information technology to bring better health to your patients and to those you are serving. I think I'm going to start with Vijaya because Vijaya, she will explain better herself. As a nutritionist, she has the opportunity to see patients through telehealth. And so she can share her experience and give us a bit of a deep dive of what it's like and how we can better manage IT to make it a positive impact on the health, particularly health of women.
So in terms of telemedicine and in terms of artificial intelligence, I think I'll speak briefly about artificial intelligence and then spend most of my time talking about telemedicine and the role it plays in bridging access. With artificial intelligence, a part of my group at Stanford attended the HIMSS conference. I don't know if any of you have heard of that conference. It's an IT conference. It's one of the largest conferences. And the 80% of the topics there that were discussed were around artificial intelligence. And ChatGPT, as most of you know, has now become a household word, I think, for many. But I think we are yet to learn how we can leverage this, and especially in maternal mortality and maternal health. It feels like it's coming on too fast. I think we need to slow down and think about how we could unleash the power of artificial intelligence. I also think it's not very new. It's been around for a long time. We've used many models, for example, for predicting cardiovascular risk scores. That is a form of using artificial intelligence when you have Framingham risk scores. So there's newness to it, but there's also things that we know. I think we just need to slow down. Going back to telemedicine, what we know is that when we examine the socio-technical fit of telemedicine, by that, what I mean is how does society and technology come together in solving problems and solving health issues? I think it's really important to understand where society is at in adopting these technologies and how do they use it. And how do these technologies speak to and educate and then evolve from these interactions? So with telemedicine, what I found in my research is that this is work that I've done at Stanford and as a part of my PhD thesis, that it definitely solves access issues. It's definitely a way for individuals to access their healthcare provider faster and is more cost effective. We looked at a study in Pakistan where they used telemedicine for maternal health, which improved maternal outcomes. So I think that there is a lot of promise there, but we still need to understand what are some ways we could unleash this. For example, infrastructure plays a big role with telemedicine, making sure that we have that local infrastructure, making sure that there's policy that supports it is really critical, because it's not just about having that one-on-one conversation with your physician, it's also about everything else that supports it.
Thank you very much. You talk about physicians. So we're going to get this physician's perspective. Dr. Bodhi, I know you see so many patients every day. And Vijaya talked about access. What do you see and how do you think that artificial intelligence, information technology, all these Twitters, LinkedIn, and telemedicine, and telehealth, and tele something helps you in your practice and make you a better servant of health for your community right here in Cleveland, because that's important for us in this conversation today. Thank you.
Telehealth evolved pretty quickly, especially during the COVID pandemic. And it's wonderful in that it gives our patients another option. So it is an option that it's available. But I think we also have to be intentional about the way we use it. in that for those who do not have access to this infrastructure, digital connectivity, or the use of a smartphone, right, it has the potential to worsen health disparities, right, with those that have and those that do not, and also depending on education level. So while it is very welcome, it has helped with access, we need to be intentional as we build the infrastructure just to make sure that that does not worsen. There are many ways that it has been proven very helpful in the clinic. I mean, with such like providing push notifications, right, for when it's time for visit, push notifications for information, health information for pregnant patients, for whatever medical condition it is, right? So in doing that, we're increasing health literacy and helping with that. It also helps with follow-up, with direct access to providers. So direct access through my chart with questions, direct access to other health associated providers, the nurses, and so on. And it has, I think, my patients find it very useful, but it does have those limitations. Speaking about artificial intelligence, you know, like Tshiya says, we've been using it for a long time, even in interpretation of tests, right? EKGs and how they can interpret. You still need people to cross-check, and breast mammograms. So it's being used all over in the healthcare fields, and it's an addition to provide quality care to patients. So yes, many positives, but we need to be cognizant of some problems that it may create, and really provide systems and policies as well. You know, I mean, we've all mentioned that a lot of this really, it's not dependent on what happens in the office or in the doctors, making sure there's that connectivity, the access of those that need it to those to digital connectivity, you know. And I know there's been a lot of talk by the policymakers in trying to see if it could be it could be classified as a needed service for everybody, and that way, you know, make sure that access is available. Thank you.
Thank you very much, Dr. Bodhi, and I truly appreciate you taking us to the road of and showing us the disparities that can happen in connectivity. I'm going to turn over to Dr. Pannenborg. I really liked what you said, Dr. Pannenborg. Well, we said we were going to be on a first-name basis, about how you started your medical journey in the 60s, and you took us to the evolution of the disparities in maternal mortality. How do you see telemedicine fit into the human resource for health? I have to pause here and say that OC co-authored a book on how human resource for health affects the health of the people that they're serving. And so I'd like to hear your perspective on how the evolution of digital evolution has affected, and I'm going to ask you a direct question. Do you think that telemedicine, telehealth will one day replace physicians? I know it's a provocative question, but I just want to hear your perspective.
Yeah, okay. What we call, let's say, what we used to call health manpower, right? Well, that's no longer acceptable, because these days you would say health women's power, but now we talk human resources in health, whatever we call it. Generally, it's called health workforce now. So, if you look at the problems that exist in the provision of health and medical care, and the pandemic has highlighted that fantastically, is the one most determining critical factor whether medical care or health care works or not are people. There are many, many studies that show that. Can have finance, money, whether it's there, or pharmaceuticals, or infrastructure, or buildings, or telecommunication, whatever. Ultimately, it's people that you need. So within that context, of course, any kind of methodology or instrument like telemedicine, etc., can be helpful when you talk with each other. But ultimately, you need a one-on-one, right? And as I know my colleague here, Dr. Bode, highlights in her work, even if, let's say, any of us here this afternoon develops a problem and somebody is going to help you with that health or medical problem, it's not going anywhere unless you as a patient or we as a patient have a trust in the person who provides it. So you need a certain level of trust. And therefore, while I agree that when you use the word physician, okay, that to me is not that meaningful. Because whether it's a physician or not, you have nurse practitioners, you have nurses, you have community health workers, you have super specialists, etc. So it's basically on the continuum of the healthcare provider. And ultimately, I think the medicine, they can help, no doubt about it. I do remember that in the early 1980s, I did work with the World Health Organization in the South Pacific. It was a wonderful time. All these beautiful islands. So you went to all these islands and said, now how can we get surgery in a remote island when, or gynecological help, there's a woman who was pregnant, she has a prolapse, nobody there. What can you do? And we tried to put a so-called South Pacific Health Network together. Well, as I said, this was 1981, didn't work. Now, 40 years later, absolutely works, right? You can all kind of help and indications. You need only one person per 3 or 4 islands, and she can, or he can, together with all the instructions on the screen and all the information. So that can be great. But ultimately, what you want is someone in your neighborhood who you trust and is part of your argument, your network. Right? And on that score, there's a big problem, because the training institutions, as we have them, whether it's here in Cleveland or in California or remote areas in Arizona or in Czechoslovakia or India, they are disconnected too often from the local communities. So the model that I argue mostly with in resource-poor settings or rich countries, doesn't matter, is a model that I learned from my years that I lived in Bangladesh. It's called the NIPORT model, the National Institute of Population Research and Training. And they started with training high school students or graduates who came out of villages immediately in the field of human reproduction. So you would, and how would you select those students? You would select them with the village community. So the villages in Bangladesh would generally have a village chief or a village council. So as the training school, you would go to the village, and ultimately Bangladesh created something like 37 or 42 of these training institutions in regions, so out in the provinces, somewhere fairly remote. The leaders of those schools would go to the villages, say, now we would like to assist the community. Can you select among your high school students 2 or 3 that would come to our training institution? We will train them for 4 years. Once they graduate, we put them back into your village, and then we will support those for providing reproductive health care to the people of your village. So here you would have someone who would be trained, leave, but come back. Everybody knows her. She would work there, and if she would do very well, so there was a career path, after 3 or 4 years, they would assess her, and then, if she's very good, would hire her back as a teacher to the institution. And then, for 1 day a week or so, or 3 days every month, would go back to her village. See, and then slowly but surely you build up a whole. So now that's a model that I think still, regardless, and maybe supported by telemedicine, etc., would create a trust and the provision of actual real healthcare in the home and in the village that would show ultimately much higher cost-effective delivery of care where it's needed.
As you discussed telemedicine, I also just wanted to bring to light a very important day, May 11th, where the pandemic as a health emergency, public health emergency that was declared at the start of the pandemic ends. So it's no longer going to be declared. So we're out of the emergency. The PHE requirements end on May 11th. And there are several repercussions because of that. For example, many of the exceptions, many of the parity laws for telemedicine, where reimbursement for a video visit was the same as an in-person visit, Medicare supporting rules for telemedicine, all of those exceptions that were put together because of the pandemic that played a huge role in enabling access are going to start declining. By May 11th, many of those exceptions will come to an end, and then more so towards the end of the year. So this was a great example. It's almost like a natural experiment where the government and the policy really coerced, in a way, the adoption of telemedicine, and it did good. But then it wasn't a magic bullet. It didn't solve all the access issues. It did increase the digital divide in many cases. So I think what we are discussing here is very meaningful, in that we finding ways where we are purposive in how we use telemedicine and how we can actually leverage the power of the community is really where I think we will be able to solve this issue of maternal health.
Thank you very much. I wanted to turn to Samira, if she's still there in Geneva. I know it's a bit late, and see, as we're putting IT and connectivity and digitalization into play right here by connecting you from across the world, I don't know if you wanted to just come in and give us a few of your experience, not only as a practitioner, but also as a policymaker, and how we can better use IT for women and giving them more access. Do you have any thoughts that you can share with us? And then we'll just ask the audience for any reactions to what we just said. Over to you, Samira.
Thank you once again, Tshiya. I think the debate you've just had is excellent, and I would like to stop at 2 points. The first one is the digital divide, which was covered very well. We know that in many parts of the world, the availability of the infrastructure is not something you can rely on in terms of health, and especially when it comes to health emergencies. So I'm going to leave it there because it's been debated very well by your panel. The second thing, and I'm zooming out of the telemedicine and the entire, automated healthcare, when, between diagnosis and seeing patients, to artificial intelligence alone. And one of the things that I would like probably to put on the table is this issue of misinformation using the artificial intelligence. While it has the potential to make a little revolution in healthcare and bring better health outcomes for people, for populations, there has to be a little bit of a caution into, of course, it's not just within the healthcare, but also outside it. So if we can probably live with the early detection and diagnosis, the personalized treatment plans, predictive analysis of tests, drug discovery, telemedicine, all of these things are very, very well outlined and used, and there's a positive experience. However, there are also many experiences where the artificial intelligence was actually used to propagate and to spread some of the misinformations that can impact how individuals perceive their care. And I stop also again at the issue of trust. I think the issue of the trust within the community is a key factor into seeking healthcare. Having said that, within our projects in the bank, we have been trying to experiment with the artificial intelligence usage, especially during COVID, because as you know, most of these clinics were either closed or repurposed. So we have a regress in the essential health services, which were replaced in some parts of the world by the use of telemedicine and artificial intelligence. But again, an important caveat to all of this, especially where we work in low and middle income countries, whether it's sub-Saharan Africa or South Asia, the caveat that we have to have is a good and functional, well-covered internet service. And this is a big caveat. It's not something that we should be taking lightly. Over. Thank you.
Thank you very much, Samira. Before I ask the audience if they have any questions, I wanted to come back to what you said about COVID and point to Dr. Bodie, who works in inner cities of Cleveland, and just to hear her experience about the misinformation that has happened during COVID and how it has impacted maternal mortality. Because we have seen in the numbers, particularly in resource-scarce areas of the US, that at some point the numbers went down between 2015 and 2018. And then maternal mortality 2019 to now has actually gone up. We were at 17 deaths per 100,000 live birth. Now we are at 27. And the US is the highest, has the highest maternal mortality rate of all the industrialized countries. In Canada, it's only 8. So how has this impacted your work? And just tell us how you think, because I know that this, for health professionals, were trying times.
Thank you. So like we've heard, the maternal mortality has gone up in the last few years. And one of the things is, why is that the case? And it's thought to be multifactorial, but I can say that one of the things that had been brought up was whether it was related to the COVID pandemic. We know at the beginning of the pandemic, a lot of hospitals and sites were closed except for emergencies, to make room for the very difficult time that everybody was going through. And so there was limited access to non-emergent problems. And people were also fearful to go to any medical facility because they did not want to get exposed to COVID. And maybe that accounted to poorer access or inability to reach care or to seek care at an appropriate time, and may have contributed to the increase in mortality rate. The jury's still out on that. We're looking at that and other things that are going on. And when it comes to misinformation, one of the questions is, how do we create a network, of a trusted network within the resources or within the framework that we have currently? How do we utilize social connections, right, to create that network so that we can mitigate some of the misinformation that went out during COVID? And I don't think it's clear how we can leverage those networks and how we can create trusted relationships among individuals, the community, and healthcare providers. I think it's something that is on the table that people are looking at and looking for ways that can be done. So that we have that network to not just disseminate information, but also to provide quality care.
To comment on what you just said, Dr. Bodie, I think while we don't know all the answers, one thought I have in terms of misinformation was something that I learned from a study that I did a couple of years ago on how dietary habits spread. And the group that I interviewed, which is about 30 or so, smaller group, they got their information about health from their healthcare provider, from the internet, or from their close friends and social ties. And turns out that they were more trusting of their social ties as opposed to, you know, the information that you get online and the information from your healthcare provider. And the social ties work quite interestingly in that within these groups, I used a technique called a snowball sampling, which is you ask a person to recommend one more person you can interview. So I knew that the group that I spoke to had some connections. What was interesting was that there were influencers within that group that played a key role in how this information was being spread. So while we don't have the answers today, I think it's wonderful for us to think about perhaps recruiting community members who serve as influencers and think about social networks differently from what we think about Facebook. But perhaps there's a way to also leverage technology there to engage close social ties in such conversations.
Look at the audience, and particularly the young people. And ask you a direct question. First, I want to thank you. You were the first here, so that shows that you care, not that the others don't care, but you made the effort during exam week. I have to highlight this, to come and listen. But I'd like to hear your views, your thought about what has just been said. And forgive me for putting you on the spot, but I think it's important that we hear from you as well, because we're not here to just talk to you, but we're here to speak with you.
Just wanted to thank you for putting this together. I'm definitely interested in maternal mortality. I've found that this is a topic that's very interesting to me. I'm a third-year BSN student, and I'm interested in becoming a nurse midwife to provide care, and this is definitely a topic that I will eventually find in my clinical practice. So, especially in the United States, being an industrialized country with our maternal mortality rate so high, this is definitely a topic that needs to be discussed and talked about, especially these social determinants of health that are impacting these care that women are not being able to receive. So I actually did have a question. I wanted to go back to talk a little bit about telemedicine. I know that through the pandemic, telemedicine was proven to be very helpful. I just wanted to ask about the gap in care that we see, just as far as not being able to fully assess our patients and how that might be missing some important diseases and issues that might arise.
I'm going to first give Dr. Bode the floor, and then Vijaya, because she's seen patient through telemedicine. So, Dr. Bode, that's your question.
That's excellent. I mean, the fact that you want to be a nurse midwife, I think our patients do not have enough options. There are no perfect options, but the important thing really is to be as patient-centered as possible and for there to be that choice. As you know, over at the beginning of the 20th century, the care of women really became very institutional based, right, with doctors, whereas traditionally it was really the community midwife who, through apprenticeship over time, especially the black midwives, had taken care of patients in the United States. And so having that option for patients for different care of healthcare providers and different care settings to take care or to deliver. Settings so far, even in Cleveland, Ohio, has also been very institutional based. There are very few birthing centers. Also, home deliveries really are, the data on that is a little bit mixed, but they're not an option, or they're not often provided. And so that would be great to expand the workforce as well as to provide those care in those areas that don't routinely have access to care. So that's wonderful. And just to go back to your question about telemedicine, yes, you're right. You're absolutely right that telehealth is limited at this point. Some of the care we do provide, though, can be done by telehealth, not all of it. Some of it can. It really depends on what the patient is presenting with. And with obstetrics, there are certain periods of time that people do have to be seen. The number of visits is increased depending on what individual conditions they have in terms of chronic disease or complications with the pregnancy and so on and so forth. But in between, some of those visits can be done, I think, pretty reasonably well over telehealth. And some of the studies showed that the maternal outcomes were the same using telehealth. It doesn't mean it was all telehealth. They still had to go for their ultrasounds and be in person. There were some in-person visits. So it was more a mixture of telehealth as well as inpatient visits. And so I heard, was that a year or two ago, that there is some development in AI where that's ongoing. I'm not an expert, but that you will be able to hear people's heartbeats or listen to their lungs over the computer. So I think all this is in progress, and people are understanding their limitations and trying to find ways to circumvent that. I mean, the really good thing about telehealth is, like, I provide care to women in the Cuyahoga County Jail incarcerated care, and it's primary care, low-risk patients who are pregnant. And they do need access sometimes to high-risk physicians, high-risk OB doctors, which often, because I am there, can be done through telehealth, and they might not need to make as many visits to the hospital. So they're kind of hybrid. I would say most of that is hybrid, but it just opens up the opportunities and the options to patients. I think that's going to get better over time.
Great point. And it's a great question. First of all, I thank you again for coming here and for engaging in a conversation like this. I'm pleased to hear your interests. In terms of telehealth, I think it serves a complementary role. It doesn't replace in-person care, but I think it can enhance care provided and can be made more holistic by augmenting in-person care. So I find that to have a complementary role. Because of the regulatory landscape changes during the pandemic, we were forced to think about how we would practice with telemedicine, right? And that led to some really interesting learnings. For example, the physical exam now can be categorized as an in-person exam or a virtual exam. On a virtual exam, there are ways that you can teach patients to position their the video to actually examine and express their condition. For example, telemedicine is very popular in wound care and post-surgery care. So these were not things that we had originally thought about, perhaps, but there were clinical spaces that were implementing and experimenting with telemedicine for a long time, which kind of became cemented after the pandemic. We do see fluctuation now as these regulatory landscapes further changing, like the PHE is going to be removed. And so people are still kind of trying to figure out what that balance is. A couple other things that I wanted to mention was that studies show that care provided by telemedicine is safe. Care provided by telemedicine is of equal or better quality. And there are very interesting ways that this have been assessed. Diagnostic concordance, for example. If you were to see a patient in person, how you diagnose them, and if you see them by video, how you diagnose them, is there a matching, right? So these are some really creative ways that this has been studied and has shown to have an effect. I still think that there are ways to go. Because of the complementary role, I think it's up to us to think about how we leverage telemedicine to our advantage. And lastly, I would say that organizations coming from the Weatherhead School with the background in management, I would say that it's important how organizations think about investments in infrastructure, because we see that regulatory landscape changes play a role, policy plays a role, but having digital complementary assets, how much the organization has invested in telemedicine, plays a bigger role in adoption within the organization. And I'm only sharing with you the perspective from the clinician, right? I think we do definitely need to engage in the other side of the conversation. But I think it's here to stay. And I think the pandemic has really offered a silver lining for us to think about different ways that we can use this to improve conditions like maternal health.
In the U.S., there is a conservative movement to restrict abortion. How do conservatives need to address the advent of more pregnancies to term and the abominable natal health care quality in the U.S., especially in conservative states? So I think the question here is that we're having, with the advent of abortion or the limiting of abortion in the U.S. and already a decline in natal services, how are we to reconcile these things in the United States and in particular with conservative states? And I think you can probably expand that to, anywhere globally where the issue of abortion is on the table, and what is the impact that where it's limited in women's health care and the services provided.
I'm going to direct the question to Dr. Bodhi first, and then maybe Dr. Pannenberg can give us a word of what he has encountered in his experience and his practice, and then maybe Vijaya can talk a bit more. But before I give you the floor, in the research that I have been conducting, I was really surprised, and that speaks to Todd's point, in the conservative states. Louisiana, maternal mortality is 78. In California, it's 2. So just within the US, we see the disparities in those conservative states. And I'm not a politician. I'm from Congo, so I'm learning. But it was striking. I learned so much during this research on how policies, and depending on which state you are and the policies that is there, affect better health outcome, and particularly for women. So, Dr. Bodhi.
Especially with abortion rights, I think it changes from time to time. And I, in my practice, have chosen to focus on reproductive health, decreasing unplanned or unintended pregnancies, right? And we have seen that the numbers of unintended pregnancies and unplanned pregnancies over years, it's going down, right? And why is it going down? It seems as if a lot of that can be related to access of contraception, right? And how has that happened? I think it's providing access to women who want contraception in teenage children, long-acting reproductive contraceptives, I think is what some of the data shows. Now, is this an association with the conservative states and what we're seeing, or is it cause and effect? There seems to be some linkage. We're not sure what that is right now. And I'm going to leave the policymakers to answer that question.
So, yeah, I think we had a graph earlier.
Yes.
Can we put it up for a second? See, here you can see what you just said. Here you can see the states in the United States that put conservative limits on reproductive health services, whatever it is, whether it's contraception, whether it's abortion, whether it's reproductive health services, prenatal visits, all that kind of stuff. And then the top line, as you can see, over the last 3 years, has really gone very high up, and the bottom line is much, much lower. See? So this shows you the correlation, which direction this goes. Now, this is kind of interesting because the reversal in what's happened over the last 120 years. Let's go to the other one. Look, here you see between, I think it was, 1800, so over the last 200 years, what maternal mortality ratios did. See? So it came consistently down, and there was, of course, an increase during the Second World War because there was nobody there, etc. And it almost hit, therefore, because here we're coming from 1,000 that I mentioned in the beginning, right? And then we go down to something like 6 or 7 on average. But now, as you can see, it goes up again. See, the yellow thing. So that is, it shows you that indeed this question is relevant. Now, what do you do about it? You can do lots of things about it, in my view, from the political point of view to the intermediate point of view that is kind of trying to provide services that are apolitical, to some interventions that I think would you could almost kind of, for the future, formulate it as, okay, let's fight back a little bit here. And since in the context of this whole discussion that we're having here today, we call it the social determinants of health, right? So housing, income, all that kind of stuff that we've discussed. Now, I'd like to take you one step further. So I don't know, and that includes my let's say, colleagues in the age cohort here in the room. Once you have a little bit of money, you can put it in your savings account, and then the bank, on your behalf, will invest it, right? That's what savings account banks do. You can also invest it yourself. Now, generally, when you invest it, the companies make decisions where they want to invest it. But the world is changing, not only in the United States, worldwide. So there are more and more shareholders of companies who say, what are you invested in? Is that socially responsible, what you're investing it in? And we all know about environmental health and climate change and all that kind of stuff. So there's now a big movement called ESG, so environmental, socially, and governmental responsible investing, ESG investing. Yeah. Even the biggest, very conservative political investment company in the United States, BlackRock, they sit on top, they invest trillions of dollars. So BlackRock has said, we are going to push for ESG investment, right? Now, the moment you go there, we are here in the School of Management. With the Inamori Center, we're entrepreneur people. They are very sensitive to investment decisions. You know, when you're a manager of a big company, whether it's pharmaceutical or ownership of hospitals or health centers, etc., the moment your big investors show up at your door and say, well, I have my doubts of what you're doing, you should be doing this, the managers are really listening, right? So I think that this ESG thing is, and since maternal mortality and we haven't even talked about maternal morbidity and disability, which is a kind of different world there. But the moment you talk about maternal mortality being determined by social aspects, including housing and infrastructure, etc., and investments, add the investment angle to it and use your investment power, your own money in your savings account, to push for more, including maternal health considerations. At the moment, it's mostly about environment and maybe about alleviating poverty or providing transport in poor neighborhoods. Just add it on. Say, excuse me, look what's happening with our women in our county or our state, and make it an issue within the ESG investment. And I think that's a way that is promising for the future. Thank you.
That's a great point. I was thinking about a slightly different angle. Without getting into the political debate about abortion rules, I think one policy level change that could be implemented is relaxation of statewide licensure rules. Right now in the United States, you have to have a license to practice in the state. So that restricts access quite significantly, right? And these rules came into being several decades ago when they never thought about medical tourism, for example, going to another state for getting, seeing the doctor. So while the national debate about abortion takes its time to settle, if we were able to relax some of these statewide licensure rules, which was relaxed during the pandemic, which has now been reinstated, we could at least ensure access. So those who are in states where such rules are present can use telemedicine and technology to at least have consultations that are within the need for physical exams. That's one way to kind of bridge the access, right? So I think federally they could think about, while actively investing in settling this debate, maybe open up access from a policy level. From a grassroots community level, I think that this should be a household discussion. We should talk about this at home. Contraception is something we should talk about at home. And if it's not comfortable, then I think you should engage in those conversations with your intimate family and with your friends, because we know that makes a difference. So I feel like that has to be encouraged, and community involvement for that, understanding the context in these different states. So we translate what we learn in clinic at a community level that is context dependent, that is culturally focused. I think if we are able to kind of have two-pronged approach like that, we may be able to make a dent.
Thank you very much. Before we go on to a little bit more discussion, I want to acknowledge the presence of our Weatherhead School director, who is here, and Ms. Sue Natker, and our associate director, Shelley Munishki. And I just wanted to hear their views about what they just heard, because I know that Sue and I had a lot of discussions during the study, and so I'd like to hear also from them and from other colleagues who are here from the Weatherhead. Thank you.
Thanks, Tshiya. We've had quite a journey over the years watching your research involve, and when I hear these statistics, I'm going, how did this happen, and how, your opening slide in one of your presentations where you show Hope, who is the face of this inequity, is to me quite heart-wrenching. So I'm glad you covered this last question in a policy way, because I'm going like, what can we do? What do we do now? How do we help Hope in Africa, Hope in the Appalachian Mountains? How do we make this inequality go away? We have beautiful children coming forward with many talents, and how do we make this child and this mother survive? So as you have talked about your research over the years, I have been so grateful to come and hear this panel about there are actually some action steps that we can all do. So if there's any other resources, any other ideas, I would love to hear about that.
Thank you. Shelley, did you want to add anything? In the back, do you have any comments?
Thank you for sharing your study.
I think it was very interesting to hear Dr. say about the mention of teaching and then bringing it back to villages and community. I think that's more like an ecosystem to me of a way of building the community. I'm very involved in the community, a part of Weatherhead to a student. I myself feel that it could be not only in the medical field, but also in different fields, technology, construction, housing, which is very important in building a community. Also, what's important is dispatch was new to me during the COVID, and that's when the nurses came to the homes. Maybe in the future, do you see doctors or maybe a mediation of teaching to people who cannot come to those facilities, but maybe reaching out to them instead?
Thank you very much for that question. I love it because it's sort of a transition into how we bring in the private sector and how we break barriers. And Todd is probably a very good resource to talk to us about how the private sector can bring some of its knowledge, and then we can just go into how we break down barriers. So thank you very much, Jerisa, for that transition.
Yeah, thank you. I think that first off, listening to the whole discussion this morning has been fascinating. I think Ak started to touch on that it's not a policy issue, that we have the opportunity with ESG as one way in which we bring the private sector into the discussion here. What we find in corporations now is, can you hear me? Oh, sorry. Oh, and better? Okay. I can hear myself, so. I say that Ak introduced the idea that we're in the private sector through ESG. And I think what we're finding in today's management environment is that socially responsible corporations are becoming the hallmark of also our most successful corporations. And so the private sector has a role to play, and us as corporate citizens then in each one of those organizations has roles to play to bring these issues to the forefront. You know, the issues that corporations put at the top of their agenda are the ones that come from their people. And it's important for the people into the organization to be able to express what they want to see organizations support. So for example, my organization, I run a food company. So we support food security issues. But women's health is not incongruent with food security issues, because really what it is health and family security issues. And what you need to do as an organization is just create the platform where people can be able to bring their views out and be able to make those views part of what the corporation's views is. And what we find in today's environment, that's more and more common with organizations, that they are bringing out the views of their people, because today's work environment is very fluid. It's very hard to attract and retain people. And if we're not listening to our people, the likelihood of retaining them becomes that much harder. So I think that's where we all can feel empowered to have our issues become part of the agenda of the corporation moving forward. So thank you for an opportunity to present those views.
Thank you.
Yeah, I like what Todd said. I'd like to take that actually one step beyond to the last point highlighted. So I make it more granular at the level of actually the university and the school. So there are two perspectives here. One is, in my view, that the school, if I understood it correctly, already since 1977 or 78, you have a course on healthcare or health services management or something like that. So, well, here you have graduate students and you train them, and I don't know the details of the course, so I don't know whether you train them in simply managing, let's say, a healthcare institution like a hospital or a health center or a pharmaceutical company, etc., and then the emphasis on managerial aspects of microeconomics or finance or returns on investment and net value and all these kind of things, or whether you mix that and include that the responsibility of, once they graduated and they go into the health sector as managers of this or that or whatever institution or organization, and that then subsequently they have a responsibility once they work there that goes beyond the immediate return on investment or the profit element or the loss element or the managerial aspects of the staff, etc. So if you don't, then my argument is expand the curriculum. Make sure that there is a responsibility in terms of the outcome and the results of the institution you're working with. Now, if you do that, then the next step is, if you do that, I would only, or you do it best, if you have students who are sensitive to it. So now graduate students is one thing, but certainly undergraduate students. So there are countries around the world where the university or the academic school or institution explicitly engages with secondary education. So as an academic institution, you go into the high schools and you engage already with students and, of course, the faculty, the teachers in those schools, for students who are 14, 15, or 13, or 16-year-old. And you try to build a constituency that then ultimately will end up in your academic institution and then have already the mindset of where you want to have them go. And that's if that works, and for example, I know an institution in Canada, McGill University, that does that, and it works. They do it even with high schools in the United States. Then you end up with already what you just said earlier, let's say what Stevenson called conditioning of the mind at age 14 or 15 on reproductive health issues. So even if the parents are very conservative, they get feedback of their children. So that's an element that I think remains important for the health workforce: trustword, mobilization, identification of ownership, all these kind of things.
I really want to thank Jerisa for bringing this up, and I thanked you a little bit earlier, but it's very important to break down barriers, and this is what we have been faced with. When I looked at the research, it's breaking down barriers. There are some communities, just in Georgia, you can't have midwives come to your aid when you need it, whereas you go to the next state and the licensed midwife can help. And so I think breaking down barriers is harnessing the potential, like Dr. Bodhi said earlier, of all the workforce. And I love that you're going to be a midwife. And I just wanted to ask our panel, how can we break down barriers? Is it in the workforce? We mentioned policy, yes, but policy takes time. And Dr. Pannenberg's example that, and we're putting Weatherhead in the spot here because we're from the Weatherhead family, goes into the inner cities or high schools in Cleveland to talk about better management. And in the long run, that might help us change the mindset. But how do we break down these barriers to give women the opportunity to carry the life that they are meant to carry, particularly in resource-poor areas when we have all these barriers? Dr. Bodhi. I'm putting you on the spot, yes.
No, that's okay. That's a really good question. I mean, I think that is a major issue with healthcare in the United States. And like the example you gave, you have access to something in the state and you don't have access in the next state. And proximity doesn't necessarily mean access, right? So in urban areas, you have proximity to healthcare and to distribution of healthcare providers. But there are many people who don't have access to it, especially people in the inner city urban areas. And we know that the health outcomes in the inner city urban areas are one of the poorest outcomes, beside proximity. So it includes, I think it includes both considering the healthcare workforce. I think Ohio actually has enough physicians, but there's some maldistribution, so that even though there's adequate healthcare providers, they're not always where the people, even though they're adequate healthcare providers, they're not always getting where people need them. So there's shortage of providers in the rural areas and in the inner city. And like we've heard, is that you have to help create a workforce that you need, right? So if you need a workforce or healthcare providers in a particular area, we found out that people stay where they have connections. So that what a lot of the push has been is to actually get young people who are interested in certain occupations from that community, right? Knowing that they're more likely to go back. And the data shows that a lot of representation or a lot of service to underrepresented minoritized people or to vulnerable populations tend to come from that population, right? So we really want to try and recruit people from there, and also to give incentives to retain them and to recruit them. So human health is HHR, human services. Also, there's the National Service Corps, right? They give incentives if you work in areas of higher need, right? In terms of paying for tuition, loan repayment, and things like that. So that way to encourage workforce, or to encourage better distribution of the workforce that exists. And then the other thing is the services that do exist, are we really taking advantage of it, right? There's so many barriers to it. So we have WIC, which is Women, Infants, and Children's Nutrition, right? And that has been around forever. But when you look at the data, only over 50% of eligible families actually use the services, because whatever those barriers is, they still cannot get access to it, right? Expanding insurance, health insurance, Medicaid expansion, right? We saw that states that had Medicaid expansion, they had some improved outcomes in certain chronic disease groups because of access. And so I think there's services that we're not taking better advantage of, and I think that there has to be more services. I mean, of course, if we had national health insurance, that would, right? But we don't. And so to find a way to still give people that access to care that they need.
Thank you. We laughed when you said national health insurance, and I'm going to turn to Dr. Pannenberg because I'd like to hear his views about that. Do you think that health insurance can break barriers to access to better health for women?
Yeah, I think it's actually a very important instrument. Not necessarily, we used to have a sense that national health insurance was the gold standard. Over the last 5 to 10 years, that gold standard has broken. And the best example is the National Health Service in the United Kingdom. It's at the moment a weekly journal, The Economist, only 3 months ago described the National Health Service as a disaster. So we've moved beyond. It's clear that it not necessarily works, right? So clearly the National Health Service in the United Kingdom is struggling enormously And the main element, like we said in the very beginning, is staff. So they simply can't get the people that they need. So, however, that doesn't mean that the approach of a National Health Service cannot be combined with other approaches. Like in the Canadian provinces, you have the provincial health services, Ontario Health Service, etc., etc. But it can be combined with private healthcare. In India, it's very clear. You have the public healthcare and the private healthcare, and in India, the private healthcare is much larger than the public one. But it's in combination with each other. And the health insurance companies that can be also. You have public health insurance companies and private health insurance companies. And across the board, both could play a highly instrumental role by prioritizing in simply the coverage package that they have and the payment that they link to it in terms of incentive money very explicitly. And here we come back to maternal morbidity, because for an insurance company, the outcome of mortality is a no-go area, right? That would already be failure for an insurance company. So they need to go to maternal morbidity, maternal risk factors, maternal disability, what's called the maternal depletion syndrome. All of that they need to cover and identify, code, and say, primary healthcare, family physicians, specialists, institutions, they get paid for this stuff disproportionately more than comparable services. So there's a big role and responsibility for the health insurance companies in this field.
I think that, so two parts to, I want to touch upon two things here when we talk about insurance. I think that it is a fantastic instrument that can be leveraged to bridge the access gap. Medicaid, as Dr. Here pointed out, is a great tool that, again, was relaxed during the pandemic, that can really help improve access to health services. Unfortunately, it becomes, insurance, having and not having insurance becomes one of the biggest barriers when you go to seek care, right? So while Medicaid coverage is very necessary, I think private companies can really contribute, especially with private insurances, to make sure that they are supporting some of these services that actually improve morbidity. Going back to the telemedicine example, prior to the pandemic, private insurance did not cover or offer parity payments for video visits compared to in-person visits. A visit usually has two portions in terms of billing, right? So there's a professional fees and there is a facility fee. Facility is where the service is offered. So video visits, private companies automatically assume that there should be no facility fee. So the reimbursement that they were offering for these visits was lower. And usually when a trend like that starts, then you obviously have a downstream effect, right? So I think one way that private insurers can, and private companies, by holding and offering insurance benefits that actually support maternal morbidity, I think is one way that we can advance this, and making this front and center and bringing women's health to the conversation being the most important aspect of a family's health.
Thank you very much with these great insights. And I know that time is not on our side, and we can continue with this conversation for the rest of the afternoon. But as I mentioned earlier, some of our colleagues are anxious because this is exam week. And so I don't want to drag this further, but I wanted to, as a closing and just wrapping up of our conversation, come back to barriers. I think there is a need from south to north, east and west, within cities, in urban areas and in resource-poor areas, to have a common understanding. And as to speak to Vijaya's point, on how we prioritize. Women give birth. Women are the essence of a community, of first as of the family, of the community, of the country. And so if we are not able to break down those barriers, we're gonna have families in disarray. Before I close and thank everybody for their participation, I want to bring you back to a story that you've heard. I'm sure it was in the media, the story of Cara Johnson. Cara was a vibrant young woman who spoke 5 languages, etc. And she went in to California, Mount Sinai Hospital to give birth. After her C-section, her husband noticed that there was blood in the catheter. I'm not a physician, so perhaps and I speak French, so I can say the word in French, but not in English. And he realized that she was bleeding. He told the nurse practitioner, who said that her patient wasn't a priority. So that speaks to the scarcity of the specialized health workforce that we need to have. 10 hours later, she was hauled into the operating room, but it was too late, and Cara lost her life, leaving her husband with 2 young children to raise. This tells us that we must continue in our own way the conversation that women are dying because society has yet to make the decision that their lives is worth saving. Thank you very much for your time, and enjoy the rest of your afternoon.